afternoon, everyone, and welcome to today's presentation titled Sharing Experiences, Building Resilience for the Future, a learning exchange on COVID-19 after action reviews. My name is Heather Hansen. I'm the manager of the Emergency Planning, Response, and Recovery team here at Public Health Ontario, and I have the pleasure of moderating today's session. We would like to begin our time together with a land acknowledgement. This webinar is being hosted and recorded in Toronto on the traditional territory of many First Nations, including the Mississauga of the Credit, Anishinaabe, the Chippewa, Haudenosaunee, and the Wendat peoples. We also recognize the enduring presence of many diverse First Nations, Inuit, and Métis peoples across the regions to which this webinar is being delivered. Please note the following disclaimer regarding the content of the presentations you will hear today. This is a brief agenda outlining the next hour and a half we'll spend together. After the presentations from our four speakers, we will have a facilitated panel discussion, followed by a period of questions from the audience. We would also like to take this opportunity to mention a few housekeeping items. The chat pod has been disabled to limit any distractions during the presentation. Please use the Q&A pod if you have questions at any time during the session. Our learning objectives for today: describe the best practices for conducting after-action reviews as part of public health emergency management, to compare and contrast different approaches that can be used, and finally, to discuss barriers, facilitators, strategies related to conducting after-action reviews to support management of public health emergencies. Okay, so now it's my pleasure to introduce the speakers for today's presentation: Yasmin Khan, Nicole Stone, Nastasia McNair, and Denise Hebert. Dr. Yasmin Khan is a physician lead in public and health protection at Public Health Ontario, an associate professor cross-appointed in the Department of Medicine and the Dalai Lama School of Public Health at the University of Toronto. Nicole Stone is the emergency planner for Haldimand Norfolk Health and Social Services. She has over 10 years of public health experience, working in a variety of portfolios. She's a champion of quality improvement initiatives, and as co-lead of the Haldimand Norfolk Health Unit's COVID-19 After Action Review, she has spearheaded efforts to assess the health unit's pandemic response and identify areas of improvement. Nastasia McNair is the manager of the Effective Public Health Practice team at Public Health Sudbury and Districts. She's passionate about integrating evidence and quality improvement in her practice. Nastasia holds a bachelor's degree in science and a master's in public health. She's currently responsible for research, evaluation, and knowledge exchange. Nastasia contributes to excellence in practice by facilitating evidence-informed decision-making and leading systematic program planning. Through COVID-19, Nastasia played a leadership role in vaccine clinic planning, partner engagement, and an after-action debrief of overall response. Denise Hebert is a program manager of emergency management at Ottawa Public Health. Her clinical areas of practice also include intervention with families experiencing complex psychosocial challenges and perinatal and early childhood mental health. Practicing in public health for over 25 years, she has held leadership roles in managing the Healthy Babies, Healthy Children's program, and during the pandemic response, the Homebound Immunization Unit, and the COVID Case and Contact Management Program. Denise has led numerous after-action reviews and the development of corrective action plans to refine strategies for future responses and build capacity through continuous quality improvement. Yasmin, we will start with your presentation.
Thanks, Heather. I'm thrilled to be starting us off today and help set the stage for our health unit presentations. Okay. In terms of our current context, we've had a recent global pandemic, and there are ongoing risks of emerging and re-emerging infectious diseases. At the same time, we're experiencing concerning impacts of climate change and related environmental emergencies. Now, building system resilience, the ability to adapt and bounce back, can support readiness for frequent and complex public health risks and emergencies. In the evidence-based framework our team developed to define all hazards public health emergency preparedness for the Canadian context, we identified 11 essential elements to support preparedness and resilience building at the public health agency level, which are depicted in this image. One of the 11 essential elements that supports building resilience is learning and evaluation. This element highlights how evaluating response to single and multiple incidents can support assessing and actioning improvements for better preparedness and response. And how evaluation of preparedness and response is described really as key to recovery if it's and successful if it's timely, prioritized, and invested in. As part of this research, an important and actionable indicator at the public health agency level that was identified was that the public health agency applies a self-assessment process to emergency management. And this process may be applied to tests, exercises, simulations, emergency plan activations, as well as agency responses. After action reviews are an established method to support learning and evaluation in emergency preparedness and response, and can be used for self-assessment for both planned exercises and real-world responses using qualitative or mixed methods techniques. This type of a review supports stakeholders and our teams reflecting on shared experiences of a response and working together to identify what worked well, what did not work, why, and areas for improvement. Overall, AARs typically aim to achieve three purposes: documenting, assessing, and improving, and aim to answer some corresponding questions. So for example, for documenting what should have happened, what actually did happen, for assessing what worked well and what did not work, and to support improvement, what actions should be taken to improve response capacity. There are a number of benefits that have been captured in the literature on the overall value of these types of assessments in the emergency management context. And those include identifying common or recurring organizational and system level challenges, institutionalizing best practice or assets within an organization that may be seen during a response, enhancing the ability of organizations to focus on systemic or other root causes as opposed to individual level performance, and improving team level effectiveness. Through the COVID pandemic, there was interest in how to best document and learn from our ongoing response efforts. In 2022, PHO published a rapid review on conducting after-action reviews as part of public health emergency management. And I'd like to walk through some evidence-informed practice takeaways from this review. So an AAR is meant to be timely. Certainly in our responses, it can be difficult to define an end date. There is also a need to build in some dedicated time and resources to plan the AAR itself. In terms of timing, it's a balance between individuals needing some time to process and reflect. But as time goes on, it will be more challenging for individuals to remember specific events or experiencing. Thus, it's recommended to carry out the AAR as soon as possible or within about 3 months of the end of an event. In terms of the team, various roles on an AAR team have been described. Roles can be held by the same person as well. Some perspectives on what to consider in building a strong team to support an AAR include looking for a lead facilitator that has familiarity with the subject matter, a response to an infectious disease outbreak or environmental health emergency. However, some distance from the direct response to ensure a more neutral facilitation. Ideally, having analysts with mixed methods expertise to support analyzing the data. and ideally building capacity over time so that team members have experience documenting these types of reviews, or at least with other types of evaluation processes. In the PHO review, it was also noted that some perspectives on the use of external reviewers can provide neutrality that allows for more candid responses and enhanced comfort of staff to be honest and open, as well as facilitate deeper discussions to identify root causes to help discern what went well and areas that need improvement. In terms of selecting participants, it's important to include a wide range, regardless of expertise or position in the organization, and certainly balanced by efficiency as much as possible and recognizing potential competing demands as well as response capacity if there's ongoing response. There are tools that can be used to support stakeholder selection as well, such as the stakeholder matrix tools. Different types of mixed methods approaches can be used to conduct an AAR, from surveys that may be more time or resource efficient to in-depth qualitative approaches such as interviews or group discussions, and workshops can also be used. AARs, it's important to note, are not intended to evaluate a team or organization's performance, but collect information to support constructive and collective learning. So in that way, AARs really do rely on open and honest and equal interaction amongst participants. Qualitative methods, approaches such as triangulation and participant validation can enhance validity and rigor of the analysis. Techniques that may be more common in quality improvement strategies such as root cause analysis may also be valuable in understanding and untangling the underlying reasons behind issues and supporting solutions. And it's important to emphasize that in after-action reviews, the results and the corresponding recommendations really should be translated into concrete actions rather than presented as too generic. In terms of analysis and dissemination, mixed methods analysis with thematic analysis of qualitative data is recommended to synthesize results. A really key aspect of AARs, both their dissemination and their impact, is that the final report can be used to develop an action plan to inform future emergency planning. And so the recommendations as well as the potential action plan should be shared with as many relevant partners as possible. Follow-up after sharing the results is also really important. And ideally, an AAR should lead to the creation of a repository of key challenges, best practices, and recommendations. And this can be captured across multiple incidents as well as their AARs. So in summary, AARs are an important strategy for self-assessment relevant to public health emergency management, and there are evidence-based takeaways to support AARs available in the PHO and the cited resources. These include the timeliness of the AAR itself and careful consideration for team and participant selection. To support documentation, the AAR can lead to creation of a repository to evaluate response to single as well as multiple incidents and their responses within an organization. Just to emphasize again, AARs are not intended to evaluate a team or organization's performance, but rather to collect information to improve preparedness and response capabilities for the future through constructive and collective learning. The AAR results and recommendations can inform an action plan for implementation and improvement, and that improvement and learning over time within the public health system can support resilience building for the complexity of public health risks and emergencies that we're currently facing. Thank you to my colleagues at PHO, and I'll turn it back to Heather.
Okay, well, I will now turn things over to Nicole.
Thank you. So thank you for having me. My name is Nicole Stone, and I am the emergency planner for Haldeman Norfolk Health and Social Services. And I'm excited to talk to you today about the process that we took at our health unit for our COVID-19 after action review. So I wanted to start with just by giving a little bit of background about our health unit and what our COVID-19 response looked like. The Haldeman Norfolk Health Unit serves just over 100,000 residents in the mainly rural counties of Haldeman and Norfolk in southwestern Ontario. We had our first confirmed case of COVID-19 at the end of March 2020, and fairly quickly, nearly all staff became involved. And while we typically have around 100 staff, we swelled to about 150 during the peak of the response, which included temporary hires as well as redeployments from our two counties. I also wanted to share a bit about how we got to our AAR because it didn't follow a typical process. So during the early recovery stages, our health unit underwent an interim strategic planning process to assist in providing direction during this transitional phase. During this planning process, an organization-wide consultation was conducted, and many team members expressed that they had faced significant challenges, and that while many were interested in talking about how to improve for future emergencies through an AAR, there needed to be a people-first approach and dedicated efforts to support people's recovery before considering how to improve operations. As a result, a mental health professional was hired to support a debriefing process, and a final report was prepared, which provided recommendations for immediate actions as well as considerations for future emergencies, which were later incorporated into our AAR. Following this process, an AAR team was established to begin the review, and our project team included our Director of Public Health as our project sponsor, a project manager, 2 project leads, and our epidemiologist. We then established an internal steering committee, which included multidisciplinary representation across all response areas. And finally, we contracted an external engagement agency to support certain pieces of data collection and analysis, which I'll go into in the methods section. And I wanted to share the makeup of this team because it was really central to our success and moving the project forward. I also wanted to share a little bit about scoping for the AAR because it was one of the more difficult parts of setting it up, especially for such a prolonged and large-scale response. Our end goal was always to improve our policies and plans related to emergency management. And like most AARs, we set out to answer the 5 key questions of what should have happened, what actually happened, what worked well, and what did not, and more importantly, why. And finally, what actions should be taken to improve response capacities. And along the side of the slide here in green, you'll see the pillars that we use to structure the review. So all our data collection methods were designed to answer those 5 key questions in the context of each of these 7 pillars. Our AAR also included the timeline between January 2020 and June of 2022, when our response had primarily transitioned to our infectious disease and COVID-19 teams. Finally, this was an internal review which engaged all staff and leaders who worked at the health unit during the response and who were still employed with the county, which included redeployed staff from other county departments, but did not include other external partners and stakeholders. And this slide outlines our process and our methodology depicted over 5 phases, which span about 9 months. The first phase was our planning and design stage, which we began with establishing our steering committee, who helped to inform the development of the plan, including scope, methods, and data collection tools. And we also underwent an ethics review with Public Health Ontario at this time. Our final plan included a mixed methods and iterative data collection approach, as depicted in the figure here, which started with internal document review, followed by an online survey to all staff, and key informant interviews with leadership, and finally, a workshop focused on root cause analysis and corrective action planning. The project leads completed data analysis of the online survey, whereas the external engagement agency mentioned before did the facilitation and analysis of the key informant interviews and workshop. And following these analyses, we conducted data validation with our AAR steering committee, and the project leads used these findings to produce 2 reports, an internal and external summarized version. Which brings us to our findings, which are highlighted at a very high level here and are definitely not exhaustive. But starting with successes or enablers, there were 3 key findings. First was that the health unit team demonstrated an incredible commitment to serving and protecting the local community. Team members were described as being flexible and adaptable, and teamwork was consistently highlighted as a strength. The response was further strengthened by the support of many partners and stakeholders, and the health unit relied on pre-existing relationships and also strengthened relationships with new partners to achieve these shared goals. And finally, the pandemic encouraged the health unit to modernize, altering some of our standard operations and resulting in innovations that can be leveraged beyond the response. The challenges, on the other hand, can be summarized into 5 key themes. The first challenge is around emergency preparedness. So we experienced challenges implementing our emergency plans and incident management system structures, especially in the context of a prolonged and complex public health response. Team members also faced an intense and persistent workload and regularly faced stressful and at times emotionally challenging situations. And related, there were common challenges identified regarding staff psychological and physical safety. Balancing the competing pressures of COVID-19 response and core public health programming was also described as a challenge, and the impacts of pausing regular programming included a backlog of work, but also included repercussions of missed opportunities and unintended impacts on the community. And finally, while modernizing was mentioned as a success, there were and continue to be technology barriers. Considering these key successes and challenges, the AAR project team identified several lessons learned and recommendations. More concrete detailed actions are provided in our internal reports, but they generally fit into these 5 overarching recommendations. The first calls for the development and implementation of a comprehensive emergency preparedness training plan, which includes things like minimum training requirements, involvement of staff in exercises, and plan orientation and review. The second is around reviewing and updating health unit plans with lessons learned so that they are functional and actionable documents. This involves the development of reference tools, which make them easier to follow and understand, and the inclusion of strategies to address staff well-being and mental health. The third recommendation is around surge capacity planning, which includes exploring opportunities to support redeployments and flexible hiring when the health unit activates its emergency plans. The fourth recommendation is around prioritizing collaboration and coordination and includes establishing joint plans on how the health unit works together with partners during public health emergencies and reinforcing those relationships that were established during the response. And finally, the last recommendation is around investing in technology, which will improve efficiency in our regular operations, but which can also be leveraged during future emergencies. And as mentioned before, 2 reports were written, which were then shared with all staff and our Board of Health. And to operationalize these recommendations, an improvement action plan was developed, which was more recently aligned with the Public Health Emergency Preparedness Framework. From there, activities have been incorporated into the most relevant team operational or individual work plans to facilitate their completion. And I think that that is it for me, but please feel free to reach out to me directly if you'd like to chat about anything further, and I will now pass it off to Nastasia.
Thank you, Nicole. So as Heather mentioned, I'm Nastasia. I'm the manager of effective public health practice at Public Health Sudbury and Districts. And so both planning and evaluation are part of my portfolio, and I was a part of our after action review team. And so again, just a disclaimer presenting on behalf of the agency. So like Nicole, I'd like to start with a little bit of a background about our health unit. So Public Health Sudbury and Districts operates in a very large geographic area. We serve a little over 200,000 individuals in our service area and about 46,000 kilometers squared in terms of geography. Within the service area, there are 19 municipalities, 13 First Nations, and 2 unceded territories. We also work with an autonomous Board of Health, meaning we aren't part of one municipality, but we work with all 19 that were mentioned. At our health unit, we also have a French language services active offer, which means that we provide services in both English and French due to our large Francophone population. So that's something to keep in mind that we did throughout our COVID-19 response, as well as part of our after action review. In terms of staffing, we typically have a little under 300 individuals working at public health submarine districts. And through our COVID-19 response, that swelled to a little over 500. So we did double in size, essentially. Now, to look at our goals and our objectives, we were really aiming for our after action review to gather feedback from our community partners, as well as feedback from public health staff. So while we conducted a lot of hot washes, continuous quality improvement activities, evaluations, community needs assessments throughout our COVID-19 response, we did set up our after action review following our peak pandemic response. So this was as we began some of our recovery activities, as individuals returned to their home teams, and really as we kind of sunset or disbanded some of the community structures that we had put in place for our COVID-19 response. So again, we were looking at that partner and staff feedback, really looking to understand experiences, including enablers and barriers, looking at how partners came together to collaborate and communicate through different roles. We wanted to identify strengths, challenges, and opportunities, and really look at feedback that could inform our response efforts and capacity planning moving forward. While we didn't necessarily use one framework to scope our AAR, we did borrow on the concepts of a SWOT analysis, so looking at the strengths, weaknesses, opportunities, and threats, and again, at the public health preparedness framework and looking at the 11 areas and recommendations for public health preparedness and readiness. So, sorry, little slide delay. In terms of our approach, we did have two key pillars to our approach. So we conducted our partner after action review and our staff after action review separately. First, we began with our partner debrief process. So this occurred through June and July of 2022, following the sunsetting of those committees. So we were looking at our overarching partner response timeline, again, from about March 2020 to June 2022. We hired an external facilitator for this process to help support, candid conversation and ensure partners felt comfortable sharing their feedback. We conducted a combined approach of focus groups and surveys. So there were 16 virtual focus groups, which were organized by sector. So we had individuals responding from municipalities, individuals who supported case and contact management, some of our healthcare providers, our school boards, really looking kind of at all the different sectors that we worked with throughout our response. We had 126 individuals participate throughout the process. And then those who couldn't attend or who wanted to provide written feedback were offered the questions in an online survey. So they were the same questions that went out via an online survey, where we had 17 additional responses. For our staff process, this occurred through November and December 2022. So once we had returned to regular teams, staff were beginning to work on recovery work. For this process, we used an internal facilitator. However, it's important to note that this individual was not involved in our COVID response directly. So it was a contract staff who worked with others, but not for our COVID-19 response. So again, trying to keep some of that impartial perspective. We held 16 virtual focus group sessions, which were organized by response function. So things like COVID behavior change, vaccine rollout, case and contact management, enforcement. And we had over 210 participants from our staff teams in these different focus group sessions. And then again, we shared an online survey where we had 55 respondents. So those were either individuals who couldn't attend or who had additional feedback to provide. Following both the partner and the staff session, our after action review team, our evaluation team, worked together to conduct a qualitative analysis of all of the results. So at each session, we had our lead facilitators, some backup facilitators, and some note takers. We used in vivo to help code thematically for key responses. And then all of the findings were grouped into summary reports and full reports. The full reports were shared with the partners for the partner debrief process. And then the summary reports were also posted to the website. For the staff findings, those were shared internally for additional feedback. So now just providing a little bit of an overview of our summary of findings. I'd like to highlight some of those that were very specific to our area, noting that there, are a number of findings that were shared with teams specifically. We did find many positive aspects and some areas for improvement. So both are outlined here according to the 11 areas of emergency preparedness. So in terms of governance and leadership, both our partners and staff really commented how being flexible and responsive and adaptive was key to our work. Having key structures and roles, so following the IMS structure, which we then broke down with our community partners as well, was really important to our response. And then again, challenges in guidance and direction. In terms of planning, we conducted a lot of ongoing and advanced planning. We created informal and formal planning committees, both internally and with partners. And we tried to engage partners as much as possible in collaborative planning. So for example, through our vaccine rollout, we created geography-specific implementation groups where we worked with representatives from municipalities, local healthcare providers, and other individuals from the different municipalities to help roll out the vaccine program. We leveraged collaborative networks that existed and tried to invest time to form new relationships as well to help with our response. We also found from community engagement that it was really important to gain situational awareness. So we conducted a few evaluations throughout the process where we were looking at a community assessment of readiness for things like COVID behaviors, COVID safe behaviors, and vaccine readiness. In terms of risk analysis, we used our agency-wide risk management framework to help inform some of the decisions. For surveillance and monitoring, data-informed implementation, including dedicated efforts for equitable response, was really important. So this is where we use some of the local data to help inform our actions throughout. And for example, if some of the data showed that vaccine uptake was low in one area, we may have worked with that group to help provide more opportunities or more clinics in a certain area. Like Nicole mentioned, we also had some challenges with systems and tools. Not all of our systems spoke to one another in the back end. So that was, of course, feedback that was presented by both our partners and our staff. In terms of practice and experience, we did try and conduct some tabletop exercises in advance of the COVID response. But of course, there was limited time for training. It came rather quickly. In terms of resources and tools, I would like to highlight that something unique that came up to our area were some challenges to access to technology. And so with some rural communities, we did find that everything going virtual and hybrid became a little bit of a challenge. However, anywhere where we could centralize supports or information was really helpful. So we created a lot of online systems or methods to share resources and tools. For workforce, we leveraged our in-house knowledge and expertise. Staff were redeployed to areas where they could maybe leverage some of their skills and best practices. Of course, the prolonged nature of our response created some challenges as it related to volume of work, staffing shortages, scheduling. And of course, we tried to implement as much as possible and saw this as feedback from both partners and staff, the importance for supports for mental health and well-being. In terms of communication, of course, responsive and transparent communication was key. Locally, we did have some additional pressures for translation of materials. So because we provide materials in English and French, that was a local pressure that was identified. And then for learning and evaluation, we did have a lot of those continuous quality improvement initiatives, but really a lot of individuals flagged the importance of opportunities for review and evaluation throughout and identifying those timelines early on. So some overarching recommendations are probably consistent with what we'd hear from other public health units, but really looking to define roles and responsibilities and key contact individuals to help support the navigation of the response. Again, looking at that flexibility and adaptability, looking to conduct as much planning as possible in advance, and then maintaining that flexible lens. Partnerships were really a silver lining throughout our response, looking at strengthening existing relationships and collaborating with new sectors. That coordinated effort and really working to clarify cross-jurisdictional issues. So for example, in our public health unit area, we have some First Nation communities that border our agency and other public health units. So we had to identify who would be working with those communities. We also created opportunities for ongoing cross-training to try and help keep staff prepared. And other recommendations included some more of those mental health and well-being supports, leveraging skills and expertise, and of course, that ongoing continuous quality improvement. So now moving forward, detailed results have been shared with teams so they can apply specific feedback to their processes or to their team functions. And then agency-wide, we are working to apply all of the findings through our emergency preparedness processes. So currently we're developing what we call a readiness checklist to help scope some of the roles and requirements provided we ever need to conduct a future emergency response. It's also really important that we continue to support a healthy and resilient workforce. So we've invested some supports and made a commitment through our strategic plan as well to ensure a healthy and resilient workforce. And then, of course, we want to continue to foster and invest in collective action. So really strengthening communities, building resilient communities so we can have the best health for all. So once again, we've shared all of our findings with our partners and then our internal findings with our staff to help action some of those tangible pieces, which are being embedded into our operational plans, our agency evaluation plans, and of course, looking at our staff development plans to continue staff training. So that is it for me. And if you have any questions, please don't hesitate to reach out. I will now turn it over to Denise.
So bonjour, good afternoon. My name is Denise Hébert. I am the program manager for the emergency management program at Ottawa Public Health. As my colleagues did, I will share the disclaimer that we've posted for this presentation, and we'll move right to background. So as I start this presentation, I would like to first acknowledge Dr. Paul Gully, a Canadian public health expert who was the consultant who completed our after-action review. The content of these slides is a summary of Dr. Gully's observations of how Ottawa Public Health responded to the COVID-19 pandemic. Dr. Gully gathered and analyzed a tremendous amount of information for us to move forward, and it was truly our privilege to have him support our work. Ottawa is a diverse community of 1.4 million people, and it covers a large geographical area, both urban and rural. OPH entered into an IMS system structure according to its emergency management plan 2 months before our first community-acquired case. The Public Health Ethical Framework for the Pandemic Response, which was published in 2020, was created to support OPH. So to give you an idea of the massive changes at Ottawa Public Health, our staff increased from 600 pre-pandemic to 3,000 at its peak, with about 85% working on the COVID response itself. As of June 2020, we'd had 75,000 cumulative cases, 824 reported deaths. Vaccine coverage was 89% for 2 doses for those 5 years and over, and 64% for those aged 12 years and over. So in September 2020, OPH reorganized from an IMS structure into a temporary long-term structure, incorporating COVID operations within that structure, along with core public health functions and the introduction of a new function to align with community needs and priority populations more specifically. Dr. Gully's report was submitted to the Board of Health in August 2022. So the scope of our review really had 4 objectives. to examine the goals of OPH to respond to the COVID-19 pandemic, whether the response was based on evidence, how the response was received, understood, and acted upon by collaborators, and also to make recommendations regarding preparedness for future events of public health significance. Our resources were, as mentioned, our external consultant, Dr. Gully, and an internal OPH support team. The audience was our Board of Health members, Ottawa Public Health employees, and community partners and collaborators. So now let's look at the methodology. So our consultant met weekly virtually with our OPH team, and our role in supporting him was to organize and provide access to the information related to our activities. He then reviewed our OPH website and more than 400 documents, including emails, reports, minutes, and conducted 22 virtual interviews across a cross-section of more than 25 staff and community collaborators. A verbal update was provided to our Medical Officer of Health as well as to our Board of Health in June 2022, followed by the final report being submitted that August. As well, Dr. Gully developed the following elements of a model response as a framework for this review. And you can see the 9 elements here were identified as listed. Goals, relationship with emergency response infrastructures, public health policy decisions, communication, interaction with Ottawa communities, with other public health authorities, with political decision makers, and involvement with staff and other public health professionals, and lastly, human resource issues. The findings for OPH as presented to the board were as follows. The review noted that OPH is a respected organization with underlying values based on equity and inclusivity. It has a leadership role in our community, and it adapted fast and frequently to provincial changes. It assessed and monitored the response of residents to public health policies and took action to promote trust and understanding of how people could protect themselves and implement infection prevention and control measures. Communication was based on data, which provided a strong foundation for the response. As most health unit, case and contact outbreak management was enormous, and they managed well through significant fluctuations in demand and approaches, as did our immunization program in collaboration with the City of Ottawa, the community, as well as traditional and non-traditional vaccine providers to ensure evidence-based equitable access to vaccines. Now, Ottawa Public Health responded to the call for action. However, there was a toll. There were long hours, separation from family and friends, and increased responsibilities. 18 recommendations were made following the review. They've been grouped as listed on this slide. I will share a few examples. One area that came up repeatedly, in fact, in 6 of the 18 recommendations, was related to preparedness for prolonged responses. So focusing on updating our emergency plans and providing IMS training to ensure cross-organizational understanding in the context of a prolonged response. There was also a recommendation to collaborate with Ontario Health Regional IPAC Hub to promote our response, for example, in supportive congregate settings. In making program priorities, it was identified that we should consider health issues that can directly be impacted by Ottawa Public Health programs and those effectively impacted through partnerships and collaborations with the community. From an evaluation perspective and research perspective, OPH needed to consider an analysis of potential adverse effects of program reductions in continuity of operations planning. One recommendation was also to review information shared with PHAC regarding travelers requiring follow-up. As for leveraging technology, I think that one speaks for itself, and my colleagues have already addressed it. We also need to prioritize human resources, specifically employee health and wellness, monitoring trends of sick leave, vacation, overtime, and providing leadership training and creating learning paths for equity-deserving groups. Okay, there we go. Last slide around implementation. So Ottawa Public Health is continuing to seek opportunities to integrate key learnings within its CQI processes. We're reviewing resource alignment with our strategic and operational plans and investing in programs including infection prevention and control and outbreak management, infectious disease prevention, case and contact management, food safety, and immunization. OPH continues to advocate for more resources. We are reviewing our emergency management plans for prolonged emergencies with, as we have tried to do through the pandemic, with an equity lens and program-specific continuity of operations plans and considering the impact of suspending some services. Progress on these recommendations is disseminated through quarterly strategic plan reporting to the senior leadership team and twice a year, in addition to the annual emergency management report, to our Board of Health. So merci, thank you, Miigwech. My contact information is here. Should anyone have any follow-up questions, I'd be glad to share the information that we have and the lessons that we've learned. Now we will move on to looking at shared findings and recommendations across our 3 health units. So we organized this information based on Public Health Ontario's Resilience Framework for Public Health Emergency Preparedness. And as was mentioned previously, this framework identifies 11 essential elements and how they interact as a complex adaptive system. So I'll just take you through these recommendations, the findings and the recommendations that collectively all of us heard about. So as would be expected, it was found that teams were dedicated, flexible, and adaptable, and structures varied based on local needs and capacity. The recommendation that applied to all of us was the need to engage in ongoing clarification of roles and expectations and responsibilities. Our emergency response plans were beneficial, but had shortcomings. Collaborative planning with partners actively engaged was observed. It was highlighted that all emergency response plans must ensure that they consider prolonged emergencies, essentially planning for longer time, but for perhaps experiences we haven't had. Everyone's response was strengthened through existing partnerships, and we need to continue leveraging those local and provincial partnerships. Through our communities, there was a lot of disinformation. The guidance changed frequently, and across the board, there was pandemic fatigue. The common recommendation pointed to the importance of building and maintaining public trust, having dedicated efforts and resources to engage priority populations. From a risk analysis indicator, all of us experienced challenges in assessing impacts of public health measures and of our actions in the community. We need to invest more in risk assessment analysis of the potential adverse effects of program reductions. From service and monitoring as well, we all had challenges with online and electronic systems. The recommendation is to engage in monitoring adverse or positive outcomes of public health actions, local data, and to inform our decisions. All of our health units had to deploy staff at some point during the pandemic who had no previous experience in responses, and the condensed training time presented challenges. We therefore need to implement comprehensive training, including exercises and cross-training as we go forward. From a resource perspective, provincial resources and technology supported our response. However, we need to streamline and centralize services and supports, so provincial level resources and technological systems. Each of our health units has challenges with capacity, with staffing scheduling, workloads, and onboarding new staff was difficult. New challenges operating in a virtual and hybrid model were also experienced. As we learn to work within this new reality, we need to support staff's mental health, well-being, and resilience, and also enhance training opportunities. All of us had challenges in keeping up with frequent changes in messaging, and it was noted that quality assurance and monitoring of communications is crucial. To do so, it was recommended to enhance coordinated communications internally with our partners and within our jurisdictions. Lastly, we all ensured ongoing learning and adjustments as needed. This was ongoing again. We also need to prioritize monitoring and evaluation through the response. And that takes us to our last slide. And I will pass it back to our moderator to take us to our next part of our presentation. Thank you.
Okay. Wow. Thank you, Yasmin, Nicole, Nastasia, Denise. That was fantastic. So yes, we will be moving now on to our facilitated panel discussion. So as you recall, at the beginning of the session, we asked you to vote on the areas that you would like our panel to discuss. So we'll start with the topic that received the most votes and work down from there with the time that we have. Okay, so the first question, I'll start back with Nicole, and we'll go through in the same order that we just had. So Nicole, can you share how your public health unit plans to continue to build capacity for AARs to support future public health emergency preparedness?
Thank you, Heather. I think we've committed to making ongoing monitoring, evaluation, and debriefing of incident response a more regular process. So this means making sure that we're conducting AARs for any activation of our emergency plans, but also acknowledging the need for more frequent reviews, such as the use of inaction reviews during something like this, like a prolonged emergency. And one thing I want to mention is the scale of this AAR was large and at times felt really overwhelming. We engaged a large number of participants by providing opportunities for the whole health unit to participate. But I think in future responses, and especially in smaller scale events, if we can ensure that other more informal review activities occur, such as hot washes or inaction reviews, which provide opportunities for everyone to provide at least some input at some level, the final AAR could include fewer participants, as long as we're still intentional about representation. And that might make it more manageable and scalable and provide the ability to use different methods that may be a little bit more engaging and may provide some richer data with a smaller group. So that would be one kind of thought around how to scale it and apply it in a different way.
Good, Anastasia, do you have any things to share on this topic?
Absolutely. So our agency really strives to commit to a culture of continuous quality improvement. And so in order to do that, we really strongly encourage that individuals build in evaluation plans, so including things like after action reviews, into their program plans. So when they're thinking about what are they going to be doing for the year, we encourage them to proactively think about how they can evaluate that. And so within our agency program plans, we do have a section for considering some of the evaluation metrics. So that's one way to try and implement it proactively in an agency system. We also really try and encourage both formal and informal opportunities. So we have a continuous quality improvement committee with champions across the agency that really try to have individuals thinking about small ways where we can improve. So maybe it's conducting an in-action review or looking at team processes. And then we have more formalized processes where we're really trying to use that debrief or AAR structure. For example, at the end of the 2023 respiratory season, we did another formal debrief where we were able to collate that information. So like Nicole, I think it's important to note, she said that, the after action reviews for COVID-19 really happened on a large scale. I think it's important to note that the same concepts can be used regularly and at a smaller scale within a team and within existing operations. Thank you.
Nice.
So at Ottawa Public Health, we've really tried to enhance how we provide professional development around building capacity around the AARs, but around the incident management structure itself, having recently changed to an incident command structure. And so we're using various templates from PHO, from FEMA, from others, and some are more complicated than others, and some require more training than others. But the objective really is to ensure that we come up with strong recommendations and then build that into a corrective actions plan. So we're reviewing some of our continuity of operations and move that to more specific program-specific continuity of operations, really engaging everyone in the process of emergency management. We've recently developed role-specific checklists and are starting to offer role-specific training around that ICS structure. As far as AARs specifically, we've done them in person, but we also are doing a few of them virtually through surveys because we can't always get, everyone is just so busy. Sometimes it's quite challenging to get everyone attending, but we found that offering the survey, either following the in-person or just doing the virtual survey has really helped us to get much more feedback. And we're also doing the AARs not only after incidences, but also after each of our exercises. And we're learning a tremendous amount through that process as well. Thanks.
Thank you. Okay, we'll go to the second most popular question. And I'll start with Nastasia for this one. Can each of you speak to how your PHU has applied the results of the AAR and what has helped with that process?
Thanks, Heather. So I touched on this a little bit through our presentation. We have taken some very specific recommendations and shared those with the teams so they can create changes to their processes. Agency-wide, we really looked at the results as a whole. So with our partners and with our staff, and what did that mean for future response? And so the biggest takeaway that I would say for us is the recommendation to create that readiness tool and that readiness checklist. And this was basically because there are so many steps that are required in an overarching response that we wanted something documented. So there were a lot of things that we did that were new or on a larger scale for COVID-19 in comparison to past IMS responses. And so we really wanted to outline what each role entailed. So what is required when you're setting up the logistics of an emergency response? What needs to be done for operations? What needs to be done for planning? Who do you need to involve? So we're really working through that checklist at this point in time, hoping that it can become a resource and a tool for the agency. We're also really looking to try and incorporate feedback into existing plans. So for example, we're currently doing our business continuity plan review. And so is there feedback that can be embedded within? So, you know, we are trying to take some of the generic feedback at the agency and then the more specific feedback for the team. So I believe there's one question in the Q&A, which we might touch on in a second, but the mental health supports and feedback as well. We've really try to incorporate more training or staff development areas that have been identified as a gap. We're trying to strengthen partnerships with individuals in the community who maybe indicated that it wasn't clear who their key contact was. So there are a few of those tangible examples as well as our agency-wide pieces. Thank you.
Denise, what are you next?
So how we're applying the after action report results is still a work in progress. It's quite long term. And we've just recently, as everyone else, reestablished our operations in a way that we're kind of referring it to somewhat pre-COVID situation. But it's important to understand that we've been managing other responses through this year. So for example, the solar eclipse, the spring freshet, measles. And so as we're in the process of collating a number of after action reports from even during the pandemic and streamlining all of this into this corrective action plan, this will inform our work going forward. and contribute to our continuous quality assurance. Much like Nastasia mentioned, we've also created checklists for each of our IMS roles, inspired by Public Health Ontario with their permission from checklists that used to exist, a number of years ago. And we've actually added an equity officer role in our ICS structure with a checklist to support that individual in really being the liaison between priority populations and our structure. That was one of our significant learnings. And I would say our biggest takeaway is the need to plan for prolonged responses. All of our plans are being reviewed with that lens, as in addition to an equity lens, but really looking at how are we planning for prolonged response. So we have a working group from my team, the emergency management team, in collaboration with other teams across the health unit. We are working on a report card to be able to report back on, are we meeting the our indicators for how we fit our work into the PHO framework, but also with our after action report, and looking at all those indicators and how they align. So I would say that's how we continue to do that work and to advocate for ongoing resources for that work. Thanks.
Nicole.
Thank you. Yeah, I agree with Denise in saying that we're kind of not too far out. It hasn't been quite a year since our final after action review was completed. And we have made some pretty good progress on some of those corrective actions and have used some of those experiences like measles and the solar eclipse and those types of things to incorporate some of the lessons learned that we found and to implement some of our recommendations. But aside from that, we've used our improvement action plan and the incorporation of those activities into team operational or individual work plans to really ensure kind of their movement forward and tracking the progress through our regular planning processes. We did most recently, as mentioned in the presentation, mapped our findings, lessons learned, and recommendations against the Public Health Emergency Preparedness Framework. And I think that was an important step recently to just, again, to reinforce the importance and to assist in prioritization, because I think there were, there's a lot of recommendations coming out of the after action review, but there are a lot of, great things in that framework as well to consider. And so mapping those against each other, I think, assisted in kind of reinforcing those pieces yet again. But it will be an ongoing and long process to complete all of these pieces.
Thank you. Okay, we'll go to our third question, and we'll start with Denise this time. What would you say were some of the primary challenges you faced conducting your AAR, and can you share any innovative solutions that were developed to overcome these challenges?
Well, we were quite fortunate, actually, in conducting our AAR because, one, we had an excellent consultant leading the work, and the ethical framework for pandemic response developed by Public Health Ethics Working Group was created to support Ottawa Public Health during the COVID response. So that really framed things really well for us. Certainly addressing staff well-being, wellness during the process was something that was not linked to a challenge per se, like in the AAR process itself. It was in the response, certainly. And I think our most important challenge was to identify and prioritize the information we were making available, because there was such tremendous information. There were so many people who can contribute, so many employees. We had 3,000. We had so many community partners, and how do you select to make sure that you get representation, you get good engagement, and you capture all the information that that you want to and need to capture. So I think that was really some of our challenges. However, as I said, we had a team working on that, and we had someone who was leading the after action review. So that's really how we overcame those challenges. Yeah, I'd say that was for us the points that I would like to highlight. Yeah, thanks.
Nicole.
Thank you. I think the two challenges that I would maybe highlight are around the staff wellness piece, as well as some of the power dynamics that can maybe be at play. So starting with that, I think we made some really intentional decisions about who would do what to ensure accountability, buy-in, and objectivity, and to address some of those power dynamics that can maybe be at play during this type of review. So we employed a hybrid approach where we had both internal and external facilitators. So our two project leads were frontline staff who had familiarity with the subject matter, and they were involved through the entire AAR process and were responsible for analysis of the all staff survey and the final report writing, which I think was really important to a lot of our team here. However, we also had our external engagement agency who, was responsible for facilitating and analyzing the key informant interviews and the workshop, which really helped to address some of those dynamics. And we were able to use both of those to compare and contrast and ensure we are still having all things considered. As for staff wellness, I touched on kind of how that was addressed. Obviously, having that debriefing process ahead of the after action review delayed the process, and it made the AAR maybe not as timely as it should have. But doing it that way really assisted us in addressing some of those pieces beforehand and helped us to narrow the scope and encourage individuals to think more specifically about operations once the time came. And I think it also equipped team members with some of the tools in the event that they needed them while going through that type of review and maybe while revisiting some of the areas of the response. So those would be the two pieces that I'd want to highlight. Thanks.
Hey, Nastasia.
Thank you. I would say that our two biggest challenges were probably a combination of ensuring that diversity of perspective and timeliness, as well as, similar to Nicole, the staff mental health and support pieces. So in terms of the diversity of perspectives and the timeliness, we worked with a number of different sectors, those that we typically work with in public health, as well as some private sector partners. And so we really wanted to make sure that we had an opportunity to get feedback from everyone. But if you recall the timelines I mentioned, we were approaching summer and we, did have to work around some vacations. So what we did to try and ensure that individuals had that opportunity to provide feedback was we pre-collated participant packages. So before each of our focus group sessions, we collated the questions in advance and we shared these out with individuals so they could come to the sessions prepared, having had an opportunity to think about, some of the strengths and weaknesses and areas for improvement. And we also then did that survey as an optional second step. So individuals who couldn't attend had that opportunity to provide things in writing. So we really tried to get creative by ensuring that invitations went out to everyone and that we had multiple methods for feedback if individuals requested. We also did offer, for those who didn't feel comfortable providing feedback in English, we provided opportunities for one-on-one key informant sessions in French. So some of our partners opted for that as well. And so that was another thing that we then got creative to make sure that we had the feedback systematically from across the service area. In terms of the staff mental health pieces, I think, staff well-being was affected across the board through our COVID-19 response. There were a lot of demands for public health units. And something that we did was we tried to incorporate a question as part of our staff debrief process. So, we did ask teams to think about if they could comment on, mental health and well-being supports that could be addressed in the future to try and gain that feedback for future improvements. and noting that there was potential, not intentional, but potential to create some challenges for staff to respond, or as they were reflecting on their experiences. We did have sort of a caveat. So again, we sent the questions to staff in advance so they were able to see and prepare. They knew what they'd be asked. And we did also send the staff questions out with an additional resource package. So staff resources that could support mental health and well-being. So whether that be our EAP program or local services that could be tapped into by our staff members if they required them. So we tried to mitigate some of those challenges in advance for both the diversity and perspective and for our staff mental health and well-being.
Thank you for your responses. So we're now going to move to the Q&A segment of this event and address some of the questions we have from our audience. So please continue to enter your questions in the Q&A if you haven't already, and we will do our best to address as many as we can. So the first question to the panel, the audience member is curious to hear how the panel, how their IMS structure did or did not change over the course of the pandemic. So for example, did it stay formal and follow a planning P model? Noting there's been substantial post-pandemic discussion onto whether or not IMS structure worked well in a prolonged pandemic.
I can start. So at our health unit, we had an initial IMS structure in the early days of the pandemic response, but we did struggle, as mentioned in the presentation, with maintaining that IMS structure throughout. Our structure continued to change over pandemic response based on priority operational areas, which had its own challenges as well. So our findings and recommendations from the AAR really considered or attempted to consider the root cause of those challenges and suggested that it may be, our familiarity with IMS, regular practice and use. So, one of our specific recommendations ended up being around health unit-wide training, more regular use of it during smaller scale incidents to encourage that familiarity and just to ensure that it's able to be used during prolonged responses and during all of our responses moving forward.
Yeah, feel free to jump in.
Okay,
Go ahead, Denise. Yeah.
Okay, I can jump in. So for our health unit, we had gone into an IMS structure in January. As soon as it was identified that something was happening, we needed to pay attention. So we went into the structure early. And what happened was we started with quite a slim structure, and then it started to swell. And I will always remember overnight we doubled, and then the next day we doubled. It was exponentially growing. And you all remember March of that year where we strike up teams of people, and then by the next day it wasn't enough. So we kept going like that, but it went quite well because we'd been experienced in using the structure before. And then in September of 2022, as I shared earlier, we moved from that structure because we needed to really integrate that work into our normal operations. So we went into a long-term temporary structure, working in some of those elements from the structures such as incident action plans and things like that we continued to use. And our work continued through the city's emergency operations center. So we weren't fully out of it, although not leading our own. We certainly integrated that into our ongoing operations. So that was our experience. And now with there's been many changes, retirements. Now we're going through another cycle of training people so that they learn how to work in, and we've changed from IMS to ICS. So providing training so that people feel comfortable as their roles will be engaged in future responses. Over to you, Nastasia.
Thank you. So like both of the other public health units, we did see some variation throughout our response. So we also struck our IMS structure in early 2020, and it continued to grow. So we had identified section chiefs early on, and then throughout our response, sometimes we had to have two individuals responsible. We ended up splitting operations into operations and continuity of operations, for example. The teams within continued to grow based on response. We were having regular emergency control group meetings, and the number of individuals who attended those varied based on the timing of response. So early on, the IMS structure really focused on, case and contact management, outbreak management, COVID safe behaviors. Later, our IMS structure ended up involving some of the vaccine response components as well, and so more individuals were added. Eventually, the number of meetings that our formal IMS chiefs had, it was daily for a while or 2 times a day for a while, those did subside. And it became built in eventually to more of our ongoing efforts. And so in early 2022, we established an agency-wide recovery plan. And as we established that agency plan, we noticed that more of the IMS structure was more pertinent to only the certain areas of work. So whether it be our control of infectious disease team or our vaccine team, and really others began to return to their regular areas. So like Denise, it swelled at key peaks in response. And then eventually we tried to embed some of the functions of those individuals into regular work and regular response, initially through recovery and now into program plans. And we tried to build it with a handoff. So anybody who'd been working in the IMS structure or as part of the COVID-19 response and was handing it off to somebody for regular work, always had a bit of a transition plan or an opportunity to do that warm handoff so questions could be asked and have some cross-training. So really, I would say some of the components are still ongoing, but as part of our regular work to this day.
Okay, our next question to the group. Are there considerations for planning when there are multiple public health emergency events occurring at the same time? Sasha, I see you shaking your head. Maybe, do you want to start off?
So I think that happened to us a couple of times. We had a few different IMS structures at once through our COVID-19 response, just based on other things that were happening locally for other emergencies. And we tried to prioritize who was working on what. So really, I think it's important to identify your leads and your key players, and then have very specific meetings focused to these areas of work. So the principles of plans for one can be applied to another, but make sure that you have really key point people and contact people to address each of the issues. Once we had established kind of our planning frameworks and our planning structure, those became templates that we could use for other emergencies. So I would say that's one silver lining and lesson learned throughout our response, but really trying to keep separate where possible, and then making sure on the flip side that there were those shared tools or resources that could be used from the lessons learned.
And I can go next. So what we've done for a number of years now is we have our duty officers for Ottawa Public Health, and they are on call, and we always plan 3 deep. So there's one person on call, 2 others essentially on standby, so that when there are concurrent emergency responses, we've already identified who's going to be the duty officer and who's going to lead us off. We also, and we experienced this a lot during the pandemic. Some of you may have remembered there was a truck demonstration in Ottawa that took weeks and weeks of resources in addition to our pandemic work, in addition to other responses we had at the same time. And so having a roster of people who have already been trained in all of the IMS roles, including from incident commander to the scribes, was really a tool that we could refer to very quickly. And so we were able to activate 2, sometimes 3 responses simultaneously. And certainly after a while, you're doing live training with people because you've got to rotate them through. But that's also an important learning that at some point we were running a 7-day operation with multiple responses, and having that roster was really important so that we're able to rotate people out and give them a rest period. So it does happen, and it has happened, and it's doable, but it's challenging.
I think that Denise and Nastasia have touched on most of the pieces here. I think it, really comes down to having those clear roles, responsibilities, and expectations, and being able to identify those individuals to be able to launch into a quick response. And also considering what some of those synergistic emergencies that might occur at any given time. So we do try in our plans to consider those things as well, so that we're anticipating what a concurrent emergency might look like as well.
Okay, this next question is directed to Nicole, but others can jump in as well. But so Nicole, and this is around sort of mental health. So our participant asked that you spoke about addressing staff burnout and psychological health and safety prior to carrying out the review, and that provided, could you provide more details on how you felt taking that affected the review? And follow-up piece is also there's interest in sort of the roles and responsibilities of the mental health specialist that you hired.
Yeah, thank you for those questions. So I can give a little bit of information about what that process looked like. So we had hired a mental health professional with experience in workforce well-being and trauma-informed counseling. And so that individual helped us come up with a little bit of a plan and facilitated group impact debriefing sessions for us. So, and as part of the whole process, we had peer support staff complete mental health first aid training to provide additional support during the debriefing process. All employees at our health unit were invited to attend virtual sessions with peers who had similar responsibilities during the COVID response with the mental health professional. And we conducted pre and post-session evaluations, which were analyzed in real time so we could pivot the model as needed because we knew kind of how delicate this circumstance was. We also had wellness workshops, which were provided to increase training for coping strategies and to provide psychoeducational resources. And then the overall debriefing process culminated in a voluntary all-staff gathering, which provided additional coping strategies, resources, and team-building activities. So really an opportunity for everyone to come together. And that was also facilitated by the mental health professional and also by various team members across the health unit. So it was a bit of a lengthier process, but it felt really worthwhile, and the results of the evaluations demonstrated some positive outcomes of that. But as mentioned before, it did affect the timing of the after action review. It did delay it. But we also felt like we were able to kind of narrow our focus and streamline because we had so many recommendations from this process that had occurred prior. So,
all right, maybe I'll go to another question. We have a bunch left. So to the larger panel, can you provide greater details regarding specific steps being taken to improve workforce capacity? It appears to be a common thread across all of your presentations.
I can start. So yes, absolutely. Workforce capacity in terms of number of individuals, but also in skills of individuals, I would like to clarify, I think, is how our agency received our findings. And so number of individuals, I think we spoke to a little bit in that where possible with support from one-time funds, we were able to increase the number of staff who were available for COVID-19 response. In terms of sustainability and ongoing response, we've really tried to build some of our casual staff, where these are individuals that we can tap on the shoulder if we need additional supports to help respond in times of increased capacity or increased pressure. So for example, we have built up our pool of casual immunizers. So if we ever need to tap on their shoulder again, that we have more individuals at the ready and onboarded with the agency. We also have some additional capacity with casual support staff for other areas. We had a casual epidemiologist on contract with us through our response. So I think that's one method. In terms of capacity for training and skill, we are currently developing a revised staff development plan for the agency where we are looking at embedding cross-training opportunities where possible. So really making sure staff who might have to be redeployed in the event of a future emergency can maintain those skills that they may have acquired throughout COVID-19 in order to be able to reapply them in the event that they need to shift areas of work. So we're really trying to build in training plans as much as possible, opportunities to mentor with another staff member, opportunities to shadow another staff member, and then formalize staff development training opportunities as well.
For us, if we're looking really at an ICS structure, what we've done is we are encouraging all of our leadership teams, so from directors, managers, supervisors, to complete their IMS 100, IMS 200 as well. We have modules that staff can complete, both with Ottawa Public Health and with the city. Also looking at updating some of our training videos. Again, that's on our to-do list because we haven't been able to tackle that with the resources we have, but they have been used in the past very successfully. And also maintaining a duty officer roster so that people rotate through that cycle 4 times a year. And that just ensures that capacity from the perspective of the responses. Leave a minute for Nicole there.
Oh, sorry. So yeah, similar to both Nastasia and Denise, it is kind of both of those pieces of looking at it from the skills capacity and also increasing, the workforce in the event that we need additional human health resources. And so we are looking into, flexible practices that we can employ during times that we activate our plans. And then our comprehensive emergency preparedness and training plan is what we're hoping to help increase the skills capacity. And I am going to pass it over to Heather so she can wrap up.
Well, this is fantastic. I want to extend a warm thank you to Dr. Yasmin Khan, Nicole Stone, Nastasia McNair, Denise Hebert for presenting today. I would also like to thank everyone who joined us for today's webinar. You can expect to receive a brief and anonymous PHO survey for today's section, so please try to complete this to help us improve our programming moving forward. Thank you for joining us and have a wonderful day.